muscle length test of the anterior middle scalenes. Patient position is supine. First thing I will be doing is fully extending my patient's head, followed by contralateral side bend and ipsilateral rotation. You feel that stretch?
Yes.
Muscle length test I will be performing is levator scap. I will be positioning my patient in cervical flexion, followed by contralateral side bend and contralateral rotation. And I am testing I'm lengthening his right levator scap. For the next muscle length test, I will be doing the upper trapezius. I will be doing my patient's right upper trapezius. First thing I'll be doing is cervical flexion, followed by contralateral side bend, and then ipsilateral rotation. Feel that stretch, sir?
Yes.
And that concludes. For the next muscle length test, I will be doing pec major, upper and lower fibers. For the upper fibers, I will be doing angles, stabilizing at the contralateral ASIS, and I am going to bring my patient to horizontal abduction to about the table length. Do you feel that stretch? Okay. Now for the lower fibers, what I will be doing is I will be moving into approximately 135 degrees of Hi, I will be doing the muscle length test of the latissimus dorsi. I have my patient supine. I will passively bring my patient to flexion overhead, and I will try to keep his arms as close to his head as possible. And my patient seems to be a little bit tight in his lats. Next muscle I will be doing the muscle length test is I'm going to ask my patient to scoot a little bit to the edge of the table. So I will be doing the biceps brachii. So first thing I want to do is I want to extend the elbow, the shoulder, pronate the wrist, and then go ahead and fully extend. You feel that?
Yes.
Okay. I will be doing the muscle length test of the triceps. So what I'm going to be doing is I'm going to ask my patient to come to the center of the table, scoot a little forward, up. Okay. So now full humeral flexion, followed by elbow flexion. They get that stretch. Feel that?
Yeah.
Alright. And then Mr. Ruiz, if you could stand up. I'll have you seated. And I have your hand right over here. Okay, so the next muscle I will be doing is the ECRL. So with the ECRL, the key here is we want to have the elbow fully extended. So just have your elbow fully extended. And then I'm going to support the forearm. And then what I want to do here is ideally I would be seated, but I don't have another chair. So I'm going to flex and ulnarly deviate the arm. Is that better for you?
Yeah.
Alright. So I'm going to flex and ulnarly deviate. Feel the stretch. Now if I wanted to assess the ECRB, I would go ahead and do the same sequence, except now the elbow is going to be flexed. So I'm going to go ahead and support the forearm, bring the wrist into flexion, and ulnar deviation. Feel that stretch? Hi, so for the next manual muscle test I would be doing is the triceps and anconeus muscle. So I have my patient laying supine. So I'm going to take my patient to approximately 90 degrees of abduction, I'm going to bring him into flexion, full extension. So go ahead and do that for me. Alright, and I'm going to bring you to 70 degrees of flexion, so not full extension. Okay, relax. So I want you to go ahead and get into that position again. Stabilize out the biceps, and then I'm going to try to bring you into further flexion. Don't let me do that. Alright, relax, and my patient will not break under strong pressure, so that is a 5x5. Hi, my name is Calderon. I will be doing the manipulation portion of the homework assignment. First manipulation I will be doing is the inferior glide of the sternoclavicular joint. I will be palpating alongside the clavicle until I get to the medial end, which is going to be the beginning of the sternoclavicular joint. I am then going to come around, and with 2 fingers I'm going to apply a force in the inferior direction. Does this replicate any of your symptoms?
No.
Normal mobility, normal end feel. Now I will be doing the same thing, palpating across the distal end of the clavicle, and then this time I'm going to push into a posterior direction. I'm going to be doing it lightly because the sympathetic chain is right underneath, so I don't want my patient to feel any symptoms. Does that replicate any symptoms? Normal mobility, normal end feel. So now the next 3 structure manips I will be doing are acromioclavicular manipulations. So I'm going to palpate across the clavicle until I get to the acromion. Here. Okay, so I'm going to stabilize at the shoulder, and my direction of force is going to be in the anterior inferior medial direction. So medial. Posterior, so the next direction I would be doing is posterior inferior lateral. Posterior inferior medial, I apologize. Hi, now I will be doing the AC joint manipulations. I will be palpating for joint alignment, going to follow the clavicle until the AC joint line. Once I'm at the AC joint line, I'm going to be palpating for joint alignment. And the direction I'm first going to go in is posterior superior. Does that replicate any of your symptoms?
No.
Okay. The next direction I will go is posterior superior medial. Replicate any of your symptoms?
No.
Now the next direction I'm going to go is anterior inferior lateral. Replicate any of your symptoms?
No.
And I just want to state that for the sake of these manipulations, in the scenario my patient has a pre-existing AC joint condition or a history of any type of surgical procedure on their clavicle, these manipulations would not be done. Hi, I will now be doing the lateral distraction of the glenohumeral joint. So I have my patient supine. First thing I want to do is find the loose back position, which is going to be approximately 20 to 30 degrees of abduction, 20 to 30 degrees of flexion, and then depending on my patient, internal or external rotation. For my patient, it seems like the internal rotation is best suited for him. So my stabilizing hand is going to be on the distal humerus, and the manipulating hand is going to be on the proximal humerus, and my direction of force is going to be in a lateral direction. Normal mobility, normal end feel. Did I replicate any of your symptoms?
No.
And I would also state I would palpate for joint alignment prior to executing the manipulation. Hi, for the next manipulation, I will be doing the inferior glide of the glenohumeral joint. First thing is I have my patient supine. Ideally, I would have a towel. I'm going to find loose pack positions. Same thing, 20 to 30 degrees abduction, flexion. My patient is more internally rotated. So I am going to have my stabilizing hand. Ideally, I would have a towel, but for today's sake, I'm just gonna have it, my hand. I'm gonna stabilize here, and then I'm going to, at the distal humerus, apply an inferior force. Normal mobility, normal infield, replicating your symptoms. Also palpate for joint alignment. Hi, the next manipulation I will be doing is posterior glide of the glenohumeral joint. Patient is supine, find loose pack position. So ideally I would have a towel. For today's sake, I'm gonna use what I have in my clinic. I'm gonna stabilize at the proximal humerus, and my manipulating hand is gonna be on the humeral head. So I'm going to apply a force in the posterior direction, and I would palpate for joint alignment prior to doing this. And does that replicate any of your symptoms? Normal mobility, normal infield. Okay, now I will be doing the anterior glide, so I'm going to keep that loose pack position, except this time I'm going to block at the scapula, and then I'm going to cup the humeral head, and then I'm going to apply a force in the anterior direction. Normal mobility, normal infield, replicating of your symptoms, and I would have palpated for joint alignment. Next manip I will be doing is distraction of the ulnar humeral distraction. I'm going to ask my patient to sit down. Alright, my patient's elbow is going to be off the table. It's going to be approximately, get him into slight flexion, and then slight supination, and then I'm going to palpate for the ulnar humeral joint on the ulna, and then I'm going to swoop. Wait, I'm sorry, let me do that again. I'm going to swoop, 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 swoop. Normal mobility, normal infield, replicating your symptoms. I did it multiple times. Hi. For my next manipulations, I will be doing the distraction of the scapula, followed by cephalic and caudal movement of the scapula. Patient position is sideline. First thing I'm going to do is I'm going to ask my patient to come in a little closer. My arm. Wait, actually. Oops. Alright, I'm going to come in. Palpate for that medial border. On that medial border here, lean back. I'm going to distract. Do you feel that? Alright, I'm going to bring it down. Now the next movements I'm going to do are cephalic and caudal movements. So for the cephalic movement, I'm at the inferior angle. Move up, bring it back down. Then I'm going to bring it in the caudal movement, bring it back to neutral. And that are the manipulations. Hi, so for my next manipulation, I will be doing the prone upward and downward movements of the scapula. So I have my patient prone, so I'm going to come underneath, get at the inferior angle, and then I'm going to manipulate it up, down, no. Hi, so for my next manipulation, I will be doing the prone upward and downward movements of the scapula. So I have my patient prone. So I'm gonna come underneath, get at the inferior angle, and then I'm gonna manipulate it up, down, no. Hi, I will be doing scapular distraction in the prone position. Patient position is prone. Going to scoop up the inferior angle, just distract. Hi, now I will be doing upward and downward rotation of the scapula. Patient position is sideline. Come underneath. Going to palpate for that inferior angle. I'm on it. And gonna be in good body mechanics. I'll do a rotational force, downward, upward, downward, upward, downward. Not replicating your symptoms? Nope. Hi, I will now be doing some hand manipulations. I'm gonna begin with dorsal and volar sweep. So I'm gonna come on the dorsal aspect of my patient's hand. I'm going to stabilize at around the CMC area, and then I'm going to do sweep in this direction, sweep in that direction. Normal mobility, normal infield, replicating your symptoms. Nope. Okay, now I will move into the MCP manipulations. I have my patient in the loose pack position, supported on the wedge. Loose pack is going to be approximately 20 degrees of flexion. I'm going to stabilize around the MCP area. I'm going to manipulate on the phalanx. Relax. Ideally. Yeah. Okay. I'll actually move up a little forward. Okay. So I'm going to do dorsal and volar. So first one I'm going to do is dorsal. So I'm at the proximal phalanx. And make sure my elbow's in plane. Exert a force in the dorsal direction. Volar. I'm going to do radial, which is going to be towards the thumb. Does that replicate any of your symptoms?
Nope.
Normal mobility, normal infield.
Cool.
Hi, so now I will be doing the ulnar glide at the MCP joint, and I will also be doing MCP distraction. So I'm going to bunch up the skin. I've got my loose pack, and I palpated for joint alignment, and 20 degrees of flexion. Bunch up the skin, distract, replicate any of your symptoms.
Nope.
Okay, I'm going to find that loose pack position again. Going to be on the proximal phalanx, and now I'm going to move in an ulnar direction. That replicate any of your symptoms.
Nope.
Normal mobility, normal infield. The next manipulations I will be doing are the dorsal and volar glides at the PIP. So I'm going to come and stabilize on the proximal phalanx, and then I'm going to come and stabilize at the middle phalanx. I'm at loose pack. I want to make sure I'm in the same plane. And then volar. I'm sorry, I said them backwards, but so this is dorsal, volar, replicating your symptoms.
Nope.
Okay, I'm going to be doing it at the DIP. I'm going to stabilize at the middle phalanx and manipulate the distal phalanx. And volar, dorsal, replicating your symptoms.
Nope.